another edition of OrthoCarolina's monthly webinar series. My name is Eddie Walker, and I will be talking today about ACL injuries. This is being live streamed on our Facebook, LinkedIn, and YouTube accounts. And please do not hesitate to ask any questions in the comments, and I will try to address them all. So a little bit about myself. I'm originally from San Diego, California, and did my medical school training at the University of Illinois, Chicago, and then did residency training at UCSF Fresno in Central California, and did a fellowship at Houston Methodist. So I have a dual board certification in sports medicine and general orthopedics. Like I said, I did my fellowship at Houston Methodist, which was a fantastic opportunity to be able to work with the Houston Texans, the Houston Astros. In fact, I got to work with them the year that they won the World Series, leading up to it actually in 2017, and then worked with the Houston Dynamo, the Rockets, Rice University, as well as the astronauts at NASA. I'm also an Army veteran and was deployed to Qatar in 2018. And as you can see there on the picture, that's 8 of my beautiful children, and I have 1 on the way. So we're expecting number 9 soon. So next slide. So I've been involved in various athletic endeavors throughout my entire life. I wrestled in high school, played tennis, football, did martial arts, soccer, gymnastics, all kinds of things. And so now as I've gotten older, I'm transitioning into different athletic endeavors. And if you look at that scuba diving picture there on the left, that little fish in the background is a 12 to 14 foot great white shark. So I went shark diving in Guadalupe Island. The picture on the upper right is climbing on the Grand Teton, and then the one in the lower right is me doing some mountaineering on Mount Rainier. So I know a lot about sports and continue to try to be as active as possible. Next slide. And then this is just a little short video, if we can get the whole thing to play, just of the latest things that I'm interested in doing. And so this is just me trying to get my skydive certification. That's what I've been up to lately. All right, so what I want to talk to you today about is ACL injuries, and they come in all varieties. Really what we're talking about are complete ACL tears, or at least even high-grade partial tears. Those generally, those require surgery. So the reason why the ACL is so important, it's the most common ligament injury in the knee. In fact, it's responsible for about half of all knee injuries. They say the incidence is about 1 in 3,500 individuals, and it necessitates about 400,000 reconstructions per year. So that absorbs, or that consumes a lot of our practice as sports medicine physicians, and is important for athletes of all ages. Next slide. So as I said, the ACL is one of the ligaments within the knee. There are 2 large ones within the knee, the ACL and the PCL. And then there's 2 big ones on the outside of the knee, the lateral collateral and medial collateral ligaments. The ACL stands for anterior cruciate ligament, anterior meaning in the front, and cruciate meaning that the PCL and the ACL form sort of this cross, this cruciform image. And the ACL provides stability to the knee in both the anterior plane and then for lateral rotatory stability of the knee. Next slide. So here's a depiction, artistic rendition here of an anterior cruciate ligament. So if you notice there on the highlighted, that ligament is in the front. As we see, the PCL is in behind it, and it forms that sort of cross image. Next slide. So ACL tears, who gets them? And we'll talk about why they happen in a minute, but generally females are about 4.5 times as likely to tear their ACL than males. So why is that? So there are several factors. Some of them are anatomic. We think that maybe what we call the intercondylar notch, where that ACL sits, is probably a little bit narrower than for the male counterparts. The ACL itself may not be as robust in its diameter, and so that may lend itself to tearing easier. There's also muscular imbalance, where the hamstrings strength, which is the muscles at the back of the thigh, may not be as strong as the quadriceps, which are those muscles in the front of the thigh. There's hormonal issues, meaning women have obviously much more progesterone, estrogen, and those types of things. And then there's also biomechanical issues, and so women tend to be what we call more genuvalgum, which means that they're essentially a little bit more knock-kneed, and so that may predispose them to ACL injuries as well. Next slide. So how do these things occur? Well, certainly most of us are familiar with the athletes that wind up developing these tears. And so if we're discussing athletics, the sports that are notorious for these ACL tears are soccer and basketball. Those are the two most common ones, especially for females. It's generally a non-contact injury, so you don't need someone to run into you for it to occur. Skiing is another big one. So for those that go out to Utah or Colorado and enjoy the slopes during the winter, just be careful. And in my experience, it generally happens to patients sort of on their last run. And some of my thinking, at least behind that, is that patients are a little more fatigued as they've been skiing all day, and they say just one more run, and they go down and they don't have the muscular control. And so when they fall, then they tear their ACL. Football is the most common for contact injuries, and so that would be a direct blow to the side of the knee, and then that can cause an ACL tear. And certainly we've seen many of those on television, primetime television, over the years. Next slide. So the mechanism by which this generally occurs, it's what we call a dynamic knee valgus. So what that means is that we are in motion. That's the dynamic part. It's not a static thing where we're just, at least for the contact injuries can be static, but for soccer players, basketball, it's generally this dynamic motion. And so what we see here, if you look at the depiction there, the hip is internally rotating. And not only is the hip internally rotating, but the foot is also internally rotating. And so you have these two ends both moving inside, while the tibia, which is the shin bone, is now moving externally. And that ACL then just cannot withstand all that force that it's experiencing, and it subsequently ruptures. Next slide. So this is a famous individual. You may know him as Adrian Peterson. And there he is sustaining that direct contact blow to that lateral, that outside aspect of his knee. And certainly I'm sure his foot is planted there. We can't see that, but that is a classic way. And in fact, I think this is how he tore his ACL. Next slide. So what do we look for? Okay. Often I will hear from athletes that they have heard a pop. That is not necessarily conclusive that an ACL tear has occurred. However, that is a good indicator that something within the knee has gone awry. The other things that I expect to hear from patients when they come to the office is that they have immediate pain and lots of swelling. In fact, oftentimes patients will come in and say that they couldn't even bear weight on the extremity initially after it happened. They needed help off the field or the court. They've needed to use crutches because it just hurts too much to put weight on it. There will generally be, again, a significant amount of swelling, and sometimes there will be bruising associated with that. The swelling occurs because when the ACL tears, there winds up being bleeding within the knee, and the knee is a capsule. It's like a big balloon, and when that fills up, it distends or gets bigger, and then that can cause a lot of pressure and pain. Next slide. So what do you expect if you think that you've had an ACL tear? Okay, so what you should expect is you've already made the decision as a patient, or you've had an injury of some kind, and you say, I need to make an appointment with my orthopedic surgeon. You give us a call, come into the office, and we're going to ask you the details of the nature of the injury. So in my experience, and for me, if a young lady comes in and she's got knee swelling and pain, one of my first questions is do you play soccer or basketball? Because that's the most common thing that's going to happen. So we're going to ask, what your activity level is, what do you do for fun, how did this happen? And then that will generally lead us down the right path of being able to diagnose this tear. The next thing is obviously physical exam. So there's lots of ways to evaluate for an ACL tear. Again, we're going to look for large knee effusions. That's just swelling in the knee where that big bag is sort of distended within the knee. Sometimes tenderness will help us, but there's a couple physical exam findings that we're going to look for. One is called a Lockman's test, where we're going to flex your knee up a little bit and then give it a shuck. The ACL is responsible for providing that anterior stability to the knee, and if the tibia glides pretty far forward compared to your normal side, then we'll say, oh, it's likely that they have an ACL tear. There's other tests out there called the Lely test and the pivot shift, and these are all very helpful in providing us with a likely diagnosis. We're also going to go ahead and order x-rays or what we call plain films. And so the rationale for ordering these plain films is to help us pick up on a few things. Sometimes we can see what we call a Sagond fracture. It's a little fleck of bone that has come off, and that is indicative of one of the other ligaments outside the knee being torn, and that can tear with the ACL. Doesn't mean that if we don't see that fracture that you don't have an ACL tear, but it will, if we do see it, then it's very, very likely that you do. One of the other things that we can look at, there's what they call a sulcus sign, and so we can see a little depression in one of the femoral condyles. So these things are, again, going to help us, lead us to the correct diagnosis, and also make sure that there's not other injuries potentially that we would be missing if we didn't otherwise get the x-rays. And of course, we always like to get the MRI. Okay, so the MRI is incredibly valuable, not so much for necessarily diagnosing the ACL tear, but really for diagnosing any other intra-articular pathology. And what I mean by that is anything else going on within the joint, whether that be a lateral meniscus tear or a medial meniscus tear or some other sort of ligamentous injury to the PCL, etc. And so that is really for our surgical planning. So that way, when we get to the operative theater, there are no surprises, and we have all the tools in our tool bag ready to go. Next slide. So, as I was saying, the MRI is very helpful for addressing or identifying other intra-articular injuries. The most common of which at the time of injury is going to be the lateral meniscus tear. And so you can see here on the highlighted region of this artistic rendition, the lateral and medial meniscus. The meniscus or menisci are the disc-shaped structures in our knee that are sort of like shock absorbers and help disperse stress across the knee. And so when the ACL tears, which is a constraint, then generally one of the meniscus, generally the lateral meniscus, will also tear. In chronic cases, we'll often see this more often on the medial side, but regardless, as the orthopedic surgeons, we like to be aware of these injuries prior to surgery so that we can plan appropriately and inform the patients appropriately what they can expect in their post-operative course and their rehabilitation. Next slide. All right, so does everybody need an ACL reconstruction or surgery? Can you live without your ACL? Those are the common questions. And so certainly there are some people that can be treated non-operatively. You do not need your ACL to live. It is a non-life-threatening injury if you tear your ACL. However, for people that are very active and want to continue in sporting activities that require cutting and pivoting, the ACL is very important in providing stability. So who are the people that don't need an ACL? Well, quite honestly, there are people that are very sedentary, that have desk jobs. They don't have any desire to play basketball or football or tennis or those types of things, and they just want to get up and go to work. They enjoy just walking, and they don't have any of that subjective instability around their knee. In that situation, I think non-operative treatment is completely appropriate. Some of those patients obviously don't have any of that laxity or that kind of subjective motion, and so they do just fine. The risks for not addressing ACL injuries is that it can cause additional cartilage injury and or meniscal injury. So the articular cartilage is what covers the end of the bone. And that articular cartilage does not appreciate what we call shear forces. And so if there's any instability as those bones rub on one another, that cartilage can sort of flake off. And so the idea is that in not addressing ACL injuries, particularly in younger people, that it may accelerate that arthritic change. So when we talk about arthritis, what we're really talking about is increased cartilage wear. Unlike other things in our body, like our fingernails, our hair, our skin, even our bones, those things want to grow back, okay? Cartilage does not do a good job at restoring itself. And hence why we do lots of joint replacements, because once the cartilage starts to wear out, it just continues to do so. So the other issue that you can have, in addition to those cartilage injuries and potential meniscal tears later, is the recurrent instability events. And so anytime that knee shifts, it can be very, very painful. And oftentimes patients will say that just continue to complain of chronic pain, or they will almost fall to their knees when those events occur. Next slide. So is it urgent or emergent? Again, this is a non-life-threatening injury. So ACLs are not what I would consider urgent or emergent. However, you do want to try to address them in a timely fashion. We think that around the 3-month mark, if you're not getting to it within the 3 to 6 month mark, that again, you may be at risk for having further cartilage damage and or meniscal injury. However, it is very important that prior to surgery, you have all of your range of motion. And so when you come to the office and the knee is large and swollen and you're having a hard time placing any weight upon it, one of the first things that we are going to ask is that you try to get all your motion back, because whatever you have going into surgery is what you'll have coming out. And the last thing you would want is to have an ACL reconstruction and then subsequently a stiff knee. So this gentleman here on the right, you may or may not know him. He was a wrestler for Iowa. His name is Spencer Lee, and he won 3 NCAA Division I titles. And he won his 3rd one without both of his ACLs. And so he was able to continue to wrestle continue to perform sports at a high level, and didn't have an ACL in either of his knees. Again, you can live without it. He ultimately got them reconstructed. He went without those ACLs so that he could win 3 titles. But he continues to wrestle at a high level, and because he wants to continue to wrestle at a high level, he wound up getting them reconstructed. Next slide. Surgery. So how do we do it? So we perform surgery with what we call arthroscopic assistance. So what that means is that arthro is the joint and scope is the way we're going to view things. We're going to make small incisions around the knee, put that camera in there, bright light, lots of water in there, fluid to help distend the area, and we're going to look around the entire knee and find anything that's wrong. So if there's a meniscal tear, we're going to address it, either cut a portion of it out or try to repair it if we can. And then we're going to reconstruct the ACL. We're going to debride a portion of that ACL stump that's still there. The reason why we reconstruct it, and I think we'll get there in a minute, is because it's 2 mop ends, this ligament that's just not going to heal. Next slide. So here's our animation of sort of what you can expect. And as you can see there, there's the ACL right in the middle of the knee. And so in this video, what they're showing is that they took what we call a patellar tendon bone graft, autograft, meaning from that patient. And what they're doing now is drilling a femoral tunnel, followed by a tibial tunnel. And that graft is going to go through those 2 tunnels into the notch. The graft is going to sit in between there where the previous ACL was, and then over time, it's going to heal. You're going to have stability back in your knee. So again, how do we do this? So when we talk about ACLs, generally what you're going to hear is the term reconstruction. Repair is meaning that I'm going to use your own stuff and put it back together. I'll talk about repairs in a brief second, but let's talk about reconstruction for now. We generally will reconstruct it with either autograft, meaning that's your own stuff, and we'll use potentially your own hamstrings, the patellar tendon bone that you just saw in the video, or your quadriceps tendon. Well, why do we do that? Well, especially if you're a younger patient, using your own stuff is infinitely better than using it from a cadaver. That cadaver is likely much older than you are, and the failure rate, especially for young patients, is much higher. So if we use a cadaver in like an 18-year-old, the chances of that re-rupturing is much higher than if we use that 18-year-old's quad tendon bone, patellar tendon bone, or hamstrings. And so that is something that you want to discuss with your orthopedic surgeon. All 3 of those grafts have their benefits and the negative side to them. However, it certainly depends on what type of athlete you are and what your expectations are concerning what type of graft may be best for you. Sometimes patellar tendon bone has greater anterior knee pain. If you're a wrestler, maybe you would want to consider either quad tendon or hamstring. But those, again, are things that should be discussed independently with your orthopedic surgeon, as their familiarity with a certain graft type and your situation will come together and make the best decision for you. Allograft is great. So that is a cadaver. That is great for older patients. And by older patients, I mean people like myself. If you're 40 or older, allograft is great. And the reason for that is because the re-tear rate drops precipitously as we age, and in part potentially because our demand is also a lot lower. Even as much as I like to go out and do athletic activities, I do them at a much lower frequency than I did 20 years ago. So it's a great option. I generally say for anybody between or 30 and younger, we generally recommend autograft, and sort of 30 to 40 can often be a dealer's choice. But again, those are things you should discuss with your orthopedic surgeon. Next slide. So what about repair? Repair has historically not been very successful. Again, it's two mop ends that just do not want to heal together because most of the tears are mid-substance. There are some tears that can have a sort of a different characteristic to them if they are what we call an avulsion. However, the repair literature has not been terribly strong. There is a new technique out there called abridged enhanced ACL repair, a bear repair. You may have heard of it. The literature only really shows that we have 2-year outcomes right now, and those 2-year outcomes seem okay. But again, that's only for 2 years. We don't have any long-term studies to really demonstrate how well this new technique is going to work over time. So if you're 18 and you're getting a bear, who knows what's going to happen at the 5-year mark. So just proceed with caution is what I would recommend there. Next slide. So what can you expect with your recovery? You can weight bear immediately, and that is dependent upon if there's a meniscal tear and your surgeon's postoperative protocol. But in isolated ACL tears, you can weight bear immediately. I typically provide patients with a hinged knee brace for additional support. The most important thing we all want to see early is we want you to obtain your full range of motion, generally within the first 6 weeks. Again, knee stiffness is a real problem that is very difficult to overcome if we don't overcome it early. You want to work on your quad strengthening. The stronger the muscles are around the knee, the more protected that new ACL will be, and the less likely you are to have a recurrent injury. When do you return to sport? I generally say around 9 months. There are surgeons that will release their patients at 6 months and some that release them closer to 12. I'm obviously in the middle. The reason for that is you're going to feel generally great by the 6 to 8 week mark and you're ready to rock and roll and return to all sports. However, we need to wait for the biology. So the blood vessels need to grow back into that graft and to vascularize it and to make it as strong as it can be. And that takes quite a bit of time. Next slide. So what are our outcomes? They're really great for ACLs. Most people do fantastic. So about 90 to 95% of patients will return to their sporting activities without any significant complications. Most athletes will return to that near the same level of competition that they were at previously. Adrian Peterson had his ACL tear. He came back and he played in the NFL. Pretty remarkable. Next slide. So how do we prevent these things? So as I was discussing before, the stronger that the muscles are around the knee, the less likely you are to injure the ACL or any of the other ligaments about the knee. There are a couple programs that out there that have really demonstrated some significant reduction in injury. The first of which is the Santa Monica Sports Medicine Research Foundation provided us with the PEP program, Prevent Injury and Enhance Performance. That's going to focus on, some jogging, a little bit of running, but your quad and hamstring strength as well as your core strength as well. And the more muscular control you can have, the better off you're going to be. Next slide. Here's the FIFA 11. Again, this is just like the PEP, and it's just going to walk you through all the different activities that you can work on a daily basis to try to help prevent any injury. One thing that I recommend for all patients with ACL tears is that whatever rehab and prevention you're doing for the reconstructed side, you want to do it for the contralateral side because you are at risk for tearing the contralateral knee, the other knee, once you have an ACL tear. Next slide. So the final thing here is just a PDF. This is a lot of information. It's certainly overwhelming. And so the American Academy of Orthopedic Surgeons does great work providing all sorts of content online for various musculoskeletal injuries, trauma, any kind of pathology you can really think of. And so you can go on there and select this PDF and it will walk you through a lot of what I've already discussed and help refresh your memory. So with that, I think we'd like to take questions now. And I see one question here. Oh yeah, can you not walk normally with a torn ACL? Absolutely, yes you can. Like I said, walking and even running in a straight line, you can do that without an ACL. There are people, though, that continue to have subjective instability, and if it feels unstable, then I highly recommend having surgery. Can arthritis develop from an ACL injury, and how often does this happen? Again, hard to know. What we think is that those people with ACL injuries, particularly younger patients, they're at risk for developing earlier arthritic changes. When we say earlier, maybe 5 or 10 years earlier than they otherwise would have, not necessarily 5 or 10 years after their injury. And so part of that is the nature of the injury again, that shearing force that happens on the cartilage surface. If you tear your ACL, does that mean you also tore your meniscus? Not necessarily. Again, that's why we want to get that MRI. It's so critical that we get it so that we have as much information going into surgery as we can possibly have to make the best choices. So there are people that tear their ACL, meniscus is unscathed, and that is an ideal situation for everyone. Can you tear your ACL by doing something other than playing sports? Yes, absolutely. In fact, I have, there's a young lady, one of my patients, who recently tore her ACL because she was walking her dog and the dog started to take off, sort of got her tangled up in the leash, and she tore her ACL. So I've had patients tear it that way. I've had some patients tear it when they just stepped off a curb. So there's a variety of ways that it can occur. Okay. Well, thank you for attending OrthoCarolina's live webinar for this month of April. This recording will be posted on our social channels. Thank you and have a great evening.